So thank you. Good morning, everyone. I'm very happy to be with you today to discuss this very important topic, which is the management of the antiphospholipid syndrome, especially in pregnant women or in women with miscarriages. So the antiphospholipid syndrome is an acquired autoimmune disorder, and it manifests clinically as recurrent venous or arterial thrombosis and or pregnancy morbidity, and this is what is of particular interest this morning. Characteristic laboratory abnormalities in the antiphospholipid syndrome include persistently elevated levels of antibodies directed against phospholipids or their associated plasma proteins, predominantly the anti-beta 2 GP1. So the clinical manifestation, as I said before, are mainly venous and arterial thrombosis. And arterial thrombosis is something very specific because usually when we talk about thrombosis in our hemostasis lab, we relate to venous thrombosis. But in this specific case, we have also arterial thrombosis manifestations. And what is of special interest today are the obstetrical manifestations. And what are they? They are early fetal loss characterized by fetal loss before 10 weeks of gestation. Late fetal loss are also observed after these 10 weeks of gestation. But there is also placental insufficiency leading to a premature delivery before 34 weeks of gestation. And preeclampsia is also part of the diagnosis. So there are also minor clinical manifestations which can relate to cutaneous manifestations, central nervous system manifestation, cardiac manifestations, so on and so forth. So there will be a lot of information in those slides. I will go very fast on some of them, but as a presentation will be available after this lecture, you may find all the information. There is also one very specific but life-threatening manifestation of the antiphospholipid syndrome, which is a catastrophic antiphospholipid syndrome. So it is rare, hopefully, but it is a very aggressive form of the antiphospholipid syndrome with a widespread thrombosis, both venous and arterial, affecting multiple organ sites, which is in 50% of cases idiopathic, but with a significant morbidity and mortality up to 50% of patients. So there are diagnosis criteria, which are involvement of three or more organ or tissues, development of manifestations in less than 1 week, histological evidence of intravascular thrombosis, presence of antiphospholipid antibodies on 2 occasions 6 weeks apart, and depending on the occurrence of these 4 clinical manifestations, you can make the diagnosis of this catastrophic antiphospholipid syndrome. So who is an antiphospholipid patient? So the primary antiphospholipid syndrome affects up to 50% of patients. What we call primary antiphospholipid syndrome is the occurrence of an antiphospholipid syndrome in a patient who has no other autoimmune disease. And then when appears, or if it appears in a patient with another autoimmune disease, then it becomes a secondary antiphospholipid syndrome. For example, if we have a patient with a lupus anticoagulant who develops an antiphospholipid syndrome, then it's considered as a secondary antiphospholipid syndrome. What is important for today is that the female-to-male ratio is quite important, meaning that it affects much more females than males, and this is of particular interest for today. So the pathogenesis of the antiphospholipid syndrome is that we have antiphospholipid antibodies. And these antiphospholipid antibodies will affect various cells of the organism, starting with the endothelial cells, the monocytes, and the platelets. And this will lead to a thrombogenic state that finally will end with thrombosis. So the antiphospholipid syndrome diagnosis, there were criteria that were proposed in 2006 in Sydney, Australia, and that we call the Sydney classification criteria. So the antiphospholipid syndrome is characterized and defined by the presence of at least one clinical criterion and the presence of at least one laboratory criterion. And what are the clinical criteria? Those are thrombosis, of course, you have understood this since the very beginning of my talk, but also for today, what is of importance for today is pregnancy morbidity with the criteria that I defined earlier. And from a laboratory perspective, you have the presence of anticardiolipin antibodies, the presence of anti-beta-2 GP1, anti-beta-2 glycoprotein 1 antibodies, and what is of utmost importance for us in the laboratory, in the hemostasis lab, is the presence of a lupus anticoagulant. And those laboratory criteria, we will see it later on, must be present on 2 or more occasions, at least 12 weeks apart. So if we look at the diagnosis of these antiphospholipid antibodies, this is an heterogeneous class of immunoglobulins, and we can detect the presence of these antibodies either using solid phase assays like ELISA assays, and you will look at anticardiolipin antibody and anti-beta-2 GP1 antibody. Or you can look at clotting-based assays, and this is, of course, what is of importance for today. And with that, you will look at the presence of lupus anticoagulant. So those antiphospholipid antibodies, they are quite frequent. And they are frequent in up to 5% of healthy subjects. So this is why it's very important to make the relationship between the presence of those antibodies and the presence of a clinical criteria to define the antiphospholipid syndrome. And what is also important for today is that these antiphospholipid antibodies are present in 15% of women with recurrent miscarriage and 20% of women below the age of 50 with stroke. So women are really at risk of this syndrome. So we have talked about the different laboratory assays that you can use to make the diagnosis of the antiphospholipid syndrome. And you can look at those anticardiolipin, anti-beta-2 GP1, and lupus anticoagulant. And as you can see on this slide, is that if you have normal subjects, the number of events here is quite limited. But if you have patients with one of these laboratory criteria, which is either anticardiolipin antibody or anti-beta-2 GP1 or the lupus anticoagulant, then you increase the risk. But if you have patients with all the 3 criteria which are positive, anticardiolipin plus anti-beta-2 GP1 plus lupus anticoagulant, then the levels of risk increases dramatically. So we will now focus more on the lupus anticoagulant. And the main characteristics of this lupus anticoagulant is a prolongation of the PTT and phospholipid-dependent laboratory assays. So they are detected by functional assays based on coag activation. And they are highly specific for the diagnosis of the antiphospholipid syndrome with a strong association with thrombotic event and fetal loss. But no assay is 100% sensitive, and there is a very high intervariability in final results between labs, and we'll illustrate this later on with the various sensitivity, for example, of the APTT reagents. And there are several guidelines that are validated and say how to diagnose the presence of a lupus anticoagulant. So then we come to practical considerations for the diagnosis of the antiphospholipid syndrome. The first question is who to test. We have seen that the prevalence of antiphospholipid antibodies is quite high, even in healthy subjects. And for this reason, we will not test every patient. So we have to select the patients in which we will make the diagnosis. And as I mentioned, and we will focus more on the pregnancy morbidity, we will look for antiphospholipid antibodies, and more specifically on lupus anticoagulants. For women with a fetal loss after 10 weeks of gestation, patients with recurrent early first trimester miscarriages, prematurity before 34 weeks of gestation associated with severe preeclampsia or eclampsia, patients with an HELLP syndrome, and patients with placental insufficiency with fetal growth restriction or stillbirth. So there are also other categories of patients in which lupus anticoagulant testing can be considered, but is not considered as mandatory, and they are listed here. So what is to be considered before lupus anticoagulant testing? Because we are relying on coag tests, and those coag tests, they may be affected by various conditions. For example, if you have a patient with an acute phase response, for example, at the time of the acute thrombotic event, but this could be also a patient with an infection or whatever, then you have to interpret with caution the results, especially because CRP, high level of C-reactive protein, which is a biomarker of inflammation, those high levels of CRP can interfere with the APTT and result in a spurious prolongation of the APTT. The anticoagulant treatment also, because it impacts the APTT and also the DRVVT test, the dilute venom, the dilute Russell Viper venom test, then those anticoagulants may lead to false positive or false negative. But when we look to pregnant women, it is also important to be very cautious when interpreting the results during pregnancy, just because you can have false positive but also false negative results. So it is advocated to repeat testing at an appropriate time post-delivery to obtain reliable results. Which test and why should we use to detect lupus anticoagulant? So all the recommendations, the international recommendation, recommend to use two different types of assays. First, the DRVVT test because of its specificity. And second, the APTT with a low level of phospholipid, just because you have to use a test which is specifically sensitive to lupus anticoagulant. And we will see that not all the assays have the same sensitivity. So you have to use an APTT with low level of phospholipids to have a sensitive test. So difference may exist between test results, even in tests with the same principle. So DRVVT and APTT pairing cannot guarantee the detection of all antibodies due to the variation in epitope specificity. So the options that could be open to overcome this difficulty is to use three different techniques, meaning one more than the DRVVT and the APTT. But this may increase the number of false positive results, and for this reason, this is not what is indicated in the guidelines. The guidelines only indicate to use DRVVT and a sensitive APTT. So we have three major guidelines which have been approved for the diagnosis of the lupus anticoagulant, and they are listed here. We have one from the British Committee, we have one from the CLSI in the United States, and we have one from the ISTH. So they all rely on the same principle. So detection of failure is a three-step process with a screening, then a mixing, and finally a confirmation test. With this confirmation test, you will add phospholipid or use a reagent with more phospholipid in order to see if increasing the amount of phospholipid in the assay, you will neutralize the antiphospholipid antibodies that are present in your plasma sample. So those three steps should be run with both the diluted resolved hypervenom test and the APTT sensitive to lupus anticoagulant, and it was used to say that this APTT reagent should be with a silica activator. This is no more true, as it has been proven that even with ellagic acid, and formerly we saw that the use of ellagic acid would not be appropriate, but now we know that depending on the reagent, if it's well validated, another activator than silica can be used. And if the three steps, screening, mixing, and confirmation, are positive with at least one test, DRVV or APTT, then the diagnosis of lupus anticoagulant is positive. You don't need to have both tests positive. Just one is sufficient to say that there is a lupus anticoagulant, but you need to run the two tests, just because one can be positive and the other negative. So as I explained, the sensitivity of the different APTT reagents varies across the reagents. So this slide illustrates, here you have various APTT reagents on the x-axis, and then you have the result to the prolongation due to the presence of a lupus anticoagulant. And you can see that you can have dramatic variability in the sensitivity of those reagents. So the typical lupus anticoagulant detection algorithm is based on the use of these two assays, DRVV and APTT. So in the first case, you have both results which are within the reference interval. And then the conclusion is that the lupus anticoagulant is not detected. So the test result is negative. Then you can have the situation where you have one of these two assays which is positive. And then let's start, for example, with the positive DRVVT test, which is above the reference interval. Then you will do the mixing with a 1-1 mixing study, meaning that you will mix one part of the patient sample with one part of a normal pool plasma, and you will look at the result. If it's normal, it means that you correct your test, and this means that you're result in the presence of a factor deficiency. But if it's still prolonged above the reference interval, or if you have an index of circulating anticoagulant which is positive, then this means that you are probably in the presence of a lupus anticoagulant. And then you will run the confirmed test with the innate plasma, and if it's corrected, then this means that you have the presence of a lupus anticoagulant. So in those three situations which are described here, either one test positive, here the DRVVT or the APTT, or if you have both tests positive, then this means that you have the presence of a lupus anticoagulant. So there is also the question of the cutoff that you should use. So I will not go through the details, but you can find information in various documents regarding these very important points. There are also recommendations of the ISTH on the report that you should do. So I will not go through this slide to keep time for showing the algorithms that we have developed, but you can find the information in the related publications. So, as I mentioned earlier, antiphospholipid antibodies are not specific. So these can be transient antiphospholipid antibodies in many cases, like infections, drugs, malignancy, autoimmune disorder, sickle cell disease. And this is why it is needed to confirm a positive result within 12 weeks apart of first determination. just to have the time for these transient antibodies to disappear, especially in the case of infection. And this is particularly true when you look at children who have frequent infections and frequent presence of lupus anticoagulants, but which are not related to the antiphospholipid syndrome. Of course, if the patient is on long-term drug therapy, you have to stop the drug to have the result without the interference of the drug, but this is not always possible. So if you want to test lupus anticoagulant in anticoagulated patients, so I told you that the presence of an anticoagulant can lead to misleading results. So there are existing strategies to overcome these interferences. So you have these specific reagents called DOAC remove or DOAC stop, which will remove the DOACs from the sample before testing. Or it has been also proposed to use different assays like the prothrombin-activated tapered snake venom time or the hecarin time, not the hecarin chromogenic assays that we do have at STAGO for measuring dabigatran, but a real clotting assay based on the use of hecarin. The issue is that those tests are not so easily available. So now I come to the final but very important part of my talk, which will focus on an algorithm that we have developed at STAGO to help you interpret the results, because you have seen that the diagnosis of a lupus anticoagulant is quite complicated, and this can be quite misleading. So we have tried to develop an instrument or an algorithm to automate the decision. And this is based on expert recommendations. We did this with an international KOL panel, and this is based on the ISTH guidelines. So I showed you the three main guidelines, the three major guidelines that we have, the BCSH, the CLSI, but we decided to follow the ISTH guideline. And the mixing and confirmation steps are launched automatically based on predefined cutoffs, and there is a computerized ratio calculation without the need for intervention from the laboratory technician, so you avoid errors, and also we'll see that you save time. And we have a uniform method of lupus anticoagulant detection, which is important because we know that standardization is so important, and we need to have reliable results from one lab to another. We have a standardized interpretation also, and this will result in a reduction of inter- and intra-laboratory variation. So how does it work? So you will launch the patient sample with both ways, the APTT and the DRVVT, and then you will calculate a ratio between the patient sample and the reference pool. And if it's negative, then we will stop. If it's positive, we will move forward. And there is a message then appearing on the screen saying the major interferences of anticoagulants that tells that UFH, low molecular weight heparin, VKA, or DOAC may interfere with lupus anticoagulant testing, just to make the lab aware of this and to check that the patient has not taken any of this anticoagulant. And then they will calculate the index of circulating anticoagulant with the mixing study that you have performed. If it's negative, it will stop, just because this is mostly the case, this is mostly what happens in the case of factor deficiency. And then it will tell you that the APTT pass is negative, or it can be also the case for DLVT. And if it's the APTT pass which is negative, they will recommend to check for factor deficiencies. So if the index of circulating anticoagulant is positive, then you will run the confirmation test, which is this Stakelot LA. If it's negative, again, this will trigger you to look at factor deficiency. But if it is positive, then you have a definite diagnosis of lupus anticoagulant. And we can say that the lupus anticoagulant is present in this specific sample, but it has to be controlled in 12 weeks and interpreted with the other antiphospholipid antibodies results, which are the anticardiolipine and the anti-beta-2 GP1 that will help to make the diagnosis and also give more information because, as you remember, if the patient is triple positive, then the risk of thrombosis or pregnancy morbidity is even higher. So, and you have the same scheme for the DIVVT pathway. So, the performance of this automated algorithm has been studied by the group of Catherine de Vries, who is really an international expert in antiphospholipid antibodies in Belgium. And you can see here the results of the studies that she has conducted. And she compared the routine lupus anticoagulant interpretation on the STAR evolution, which means without the algorithm, and with the algorithm. And what she found is that this algorithm has a sensitivity of 76%, which is quite good, but the specificity is very high, 99%. And this means that because the specificity is so high, you reduce the number of Stacklot LA tests by 10%, which are needed. And this reagent is, of course, a source of cost. And as all institutions are very focused on cost today, then it's very important. But furthermore, they think that they found that for 30 samples, the hands-on time decreased by 60% from 200 to 80 minutes. And in a time where laboratory resources are so important and limited, it's important also to save time. So the take-home messages of this presentation is that lupus anticoagulant testing is part of the antiphospholipid syndrome diagnosis. We have seen that the lupus anticoagulant testing is a complex multi-step. We have seen that there are 3 different steps with the screening, the mixing, and the confirmation. Multi-reagent, 2 reagents, APTT, sensitive APTT, and DIVVT. And there are many pitfalls in lupus anticoagulant testing and interpretation. We have talked about the presence of interferences, especially in patients with anticoagulants, but also at the time of the acute event or during pregnancy or in patients with high levels of CRP. And finally, I think we can conclude that an automated algorithm improves the standardization and reliability of testing while saving reagents and manpower. And if you want to continue and know more about this, I would recommend this practical manual on antiphospholipid syndrome that we have produced a couple of years back, but it's still valid. And it's been produced with an international expert panel. And Catherine de Vries, who was the one who helped develop the algorithm, was also part of these authors. And we have other resources for you to know more about lupus anticoagulant testing. We have postcards, we have webinars, and so on and so forth. So with that, I will conclude, and thank you for your attention.